Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speakers. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Jonas, Benson, and Dr. Kiriluk of Uro Partners. Dr. Benson graduated with honors from the University of Iowa. He received his medical degree from the University of Missouri. After finishing near the top of his medical school class, he went on to complete his internship and urology residency at Rush University in Chicago. Lastly, Dr. Benson completed his endourologic fellowship at Loyola University Medical Center in Chicago. Dr. Kiriluk received his Bachelor of Science from the University of Illinois in Urbana-Champaign, then went on to receive his medical degree from Rush University Medical Center in Chicago. Lastly, completing a general surgery internship and urology residency at the University of Chicago. Thank you for joining us tonight, and now I'll turn it over to Dr. Benson to get us started.
All right, thanks for participating. We'll go through these slides. We'll go through each topic. I'll start off talking about erectile dysfunction, specifically in regards to the penile implant. And then we'll switch over and Dr. Kiriluk will finish up the discussion talking about incontinence and his portion of the procedure. So again, thanks for joining us. I apologize if my kids come running in here. If they do, just understand that I can't control them. They're wild animals. So here are us. I got a nice introduction, and so did Dr. Kiriluk. I don't need to go over this. In brief, we'll just go over erectile dysfunction now. We'll talk about all treatment options, and then I'll go into detail about the implant. So what is erectile dysfunction? It sounds like a simple question. The answer is more complicated than you'd think, but sometimes you just don't want to overthink things. The reality is it's just the inability to maintain an erection that's useful enough for intercourse. It's extremely common in this country. About 1 in 5 men will have some type of erectile dysfunction in their lifetime. And this starts around the age of 20. When you get over the age of 40, it's much more common. We're talking about 50% of all men have some type of erectile dysfunction. When you look at population data, we're going around 40 million people. So how do erections work? I'm going to skim over this. The knowledge and the physiology of how erections work are something, if you really, really want to know, you can go into a medical textbook and read about it. But just understand there's essentially 2 balloons in the penis, and they have an in and an out. Functionally, it's all controlled by blood flow. And you hear that quite often when people talk about erectile dysfunction. The arteries put the blood in, the veins let the blood out. The blood has to be trapped, and this process is relatively complicated. But the gist of it is you can think of it like 2 functional balloons in the penis that go up and down when you get aroused. So we know about the lack of ability for erections to be useful for intercourse. Now, where do you go outside of that realm? Guys don't particularly like to talk about it, and I'll be honest, most urologists don't particularly like to talk about it. It's the personal aspects and the distress that's caused by erectile dysfunction. Let's just say it can be very troublesome. It can range from, hey, this is kind of annoying, to this is the worst things that happen to me, and everything in between. So it just understand it does affect other aspects of your life. So where does it come from? We get this question quite often. Dr. Kiriluk, I'm sure, can confirm this, but people come in and say, okay, I have erectile dysfunction, I can't have sex. Where's it? What happened? What's going on? This slide gives you a general idea. The 2 most common forms are diabetes and vascular disease. So these both cause damage to the blood flow. Thus, that's why it's a common cause of having erectile dysfunction. There are obviously many, many more. Medication is one. Blood pressure medication is one that's very common. But you add these all up and you start getting to that 40 million people that we've been talking about from the earlier slide. The other question that gets really common is, can you fix it? If I just fix these problems, are my erections going to get better? The short answer is no. You need to live healthy and be healthy, but when it comes to reversing erectile dysfunction, it's relatively uncommon for it to go away by correcting something that's already happened. So a little bit of focus on diabetes, because diabetes is so common in this country. Diabetics tend to have worse erectile dysfunction than other populations. And then about 50% of people with diabetes feel that erectile dysfunction is bothersome and it is troublesome in their life. When we talk about heart disease, we're talking about vascular disease. This slide, it goes into kind of more detail of how arteries are affected and how they control erections. The gist of it is if you look at the arteries that let the blood go into the penis to cause erection, they're very small arteries. Thus, they're fragile and they can be damaged by things like diabetes and cardiovascular disease. In fact, we now know that erectile dysfunction even happens sooner than, say, a heart attack or a stroke. And that's just due to the size of the arteries. The small arteries on the left on your screen, the larger arteries on the right. And you can see that depending on what symptom you have, the penile arteries are the smallest. So you tend to have those problems first. So for those who have had prostate cancer or treatment for prostate cancer, either radiation or surgery, this is focused more for you right now. You can look at the anatomy of the prostate, but in general, the nerves that are turning the on-off switch for your erections are run right down the side of the prostate and actually integrate into the prostate. When the prostate's removed, if you're lucky enough to have those nerves spared, just depending on the severity of your cancer, those on-off switches are hopefully still intact. Even when they are intact after prostate cancer surgery, typically your erections aren't as strong as they were before the surgery. So this statistic is always kind of brutal, but after prostate cancer surgery or treatment, the range of erectile dysfunction is anywhere from 25 to 75%. It's kind of a poor statistic, but it's real. It's just kind of going to the point that it's highly variable what's going to happen after prostate cancer surgery, and understand that I tell my patients that if you have prostate cancer, just plan on your erections being worse in some way, shape, or form. The severity is just highly variable. I should mention on this last slide that whether you had surgery or you had radiation, they both get erectile dysfunction. Real brief about Peyronie's disease. You may have seen the commercials on TV for the new medications for injections on Peyronie's disease. It's more common than people think. Somewhere between 6 and 8% of the population gets Peyronie's disease. Strangely enough, it's just a scar that develops in the balloons inside the penis, and you get a bend. Along with that bend, you can have erectile dysfunction, and it kind of makes sense if you look at this graphic over here. Scarring results in less blood flow equals decreased erectile function. So again, very common. This happens in 6 to 8% of the population, and it is something that can result in erectile dysfunction. So treatment options. Most people are familiar with the medicines. The medicines, we're talking Levitra, Viagra, Cialis, Stendra. These are all pills that you can take. Now, we have online available options. People have probably heard this stuff on the radio, Blue Chew, and these other types of medicines that you can get from a doctor on the internet. The gist of it is they're all the same type of medicines. You take a pill, about an hour or so later, you hopefully have improved erections. Injections, also known as ICI, that's where you put medicine directly into the balloon tissue in the penis to cause erections. We'll go into more detail about the implants, the vacuum devices. And then there's also a medicine that, strangely enough, goes down the tip of the penis and deposits the medicine in there. And we'll go over each briefly. Okay, erections, I went over the names of them. You don't really need to be taught that. Just know that there's a bunch of them, and they tend to work pretty well. I mean, they work somewhere between 50 and 80% of the time. It is harder if you're a diabetic or you've had prostate cancer. Those are the two people that they tend not to work as well at. And then the different brands and the different types all have a different duration. So you can range anywhere from 4 to 6 hours all the way up with Cialis can last 1 to 2 days. Keep in mind, these medicines all need stimulation. So you can take the medicine, you won't get an erection, but you'll need some stimulation to help from an arousal standpoint to get the process going. So side effects, headache, flushing, stuffy nose, muscle aches. Some people get some reflux or some GERD. There are contraindications to the medicine. Some people can't take them. Obviously, if you have questions about this, your primary care doctor is the first person to talk to, and then you can talk to an expert like myself or Dr. Kiriluk as well. So vacuum devices, real brief on this. You put a pump on your penis, you push a button, it pulls blood into the penis, and then you put a ring, or what they call on here a tension ring, and that holds the blood in the penis. They tend to cause a nice erection for a few minutes, and then the blood slowly flows out. A lot of times you have to re-inflate, for lack of a better term. The statistics on this slide says 60 to 80% satisfaction rate. I'll tell you that stat is extremely high. You can look at other data, and we're talking more around the 20 to 40% satisfaction rate. These cost somewhere between $200 and $400. Insurance typically doesn't pay for them. And I'll tell you, most people just leave them in the drawer and don't use them. Side effects, you can read through that if you like. Essentially, you can get a little bruising and a little discomfort. The main one is people don't like the ring. It's relatively uncomfortable. It tends to pull on any hair if you have hair. People just don't really like it. Also, it's kind of a bummer to pull the thing out, hear the little pumping process going and sitting and waiting for it to work. The suppository, the other name, that common name is called Muse. This is when you put medicine into the penis down where the urine comes out. The main complaint with this is burning. It tends to burn relatively badly. If it does, some people don't notice the discomfort. And people don't like really having sex whenever they've got a burning penis. So also, it's hard to find. The medicine isn't very distributed very well, and getting the doses is hard. You could literally not find this in Chicago, depending on how the manufacturing is going. So, but I'll tell you, some people like it, and people, mainly people who are afraid of needles, this would be your next best option. Speaking of needles, this is called ICI, or Intracavernous injection therapy. It's when you take a needle with some medicine, you pull it out of the refrigerator, you draw up the medicine, you put it into your penis when you want to have intercourse. It works pretty darn well. The medicine is very strong. You can think of it like Viagra going straight into the penis, okay? Does it work? Yeah, it works pretty good once you get your dosing down. Again, it's cumbersome. You have to travel with the medicine. The majority of the time, the medicine needs to be refrigerated. It also breaks down relatively rapidly, meaning if you have it for 6 months, it's probably not going to work. You'll have to get new or have it brought in. I'm warning you, everybody, there's going to be some kids running around here, so I apologize. So that's the injection therapy. Does it work? Yes. It tends to be an issue for some people who are afraid of needles. The way we do it in our practice is you would come in, we show you how to do it, we get you dosed, and then the medicine gets mailed to you. So that's the injection therapy. Now we'll go into the implants. I am going to step out and close the door real fast. Hold on one sec. Sorry about that. So on to the implants. I should let you know, everything that we've gone through, or I've gone through so far, is available at our office in Wheaton and Geneva. We all participate in this process. I'm the one who does this portion on, meaning if you come to our office in Wheaton and Geneva, I would be the one who does your implant for the erection. So that's why I'm the one talking to you now. But all the other options are available, and you can talk with any of us in the office, or specifically myself or Dr. Kiriluk. So, okay, on to the implants. The implant, you can see the diagram here. There will be a video. You don't need to squint and look at that. But functionally, you can think of it like a friend or maybe even yourself who's had a hip replacement or a knee replacement, it's the same type of process. You get a mechanical device put inside your body, and it does something that your body can't do any longer. It's all on the inside. You can't see it. And it's a surgery to put it in. So do they work? Yeah, they work. And if you look at satisfaction scores, we're talking around 98% satisfaction. That satisfaction includes partner. So it's not just you, it's the person you're with. They both like them. Why? Because they work. So we'll have a little video here. I'll try and get it to work. I hope everyone can see it. The video itself is just going to show you kind of how the device works. So this is the inside, obviously. There's a little pump here, and then you squeeze it, and it pulls fluid in from a reservoir in your belly, and then it causes a firm erection. This device here, it looks like an LGX. It's just a nice version of this implant where it actually gets wider, so you gain a little girth with this implant. To release the implant, I'll pause this for a second here. There's a button that you push to, here, but the pausing is failing. Yeah, sorry, it goes away. So I'll just let it run just for a second here. But a button that you push, and then you squeeze the fluid out of the penis, it goes back into the reservoir, and you're functionally flaccid again. All right, so benefits of an implant. It's permanent. So when you want it, you can use it. It gets the spontaneity back to intercourse. Ask patients that bring your partner in, let them pump it up. It's a fun little toy. Erections can last as long as you want. That whole process of, wow, I lost my erection after 3 minutes and my partner was not happy, didn't get satisfied, that doesn't happen anymore. I mean, it sounds crazy. You could go for an hour if you really wanted to. The things inside your body, you can't see it. You would have to have a pretty good inspection for someone to know that you have it. It does not mess with ejaculation or orgasm. Your sensation typically stays the same. These things have been around since the 70s. Obviously, there's been improvements, but that's how long they've been around. And there's around 500,000 of them running around. And this includes people that you would know. And I won't go into the details of that, but if you wanted to Google, there are famous people out there who actually promote these things. It's kind of interesting. So insurance, people always wonder, well, how much do these things cost? Yeah, they're expensive. When you're getting something put into your body, it's going to be a little costly. Thankfully, most of the time, insurance does cover it. Now, I don't want people to get frustrated if insurance doesn't cover it. There are over 40 insurance plans in the state of Illinois alone. We cannot predict whether yours will cover it or not. I can tell you in general, Medicare covers these procedures. If Medicare covers it, most private insurances cover it. You will have a copay or a deductible, but that's based on your current plan. So in general, it is covered, and it is something that insurance is paid for. So we have to go into the bads. There are risks with any surgeries. Obviously, you have to talk with your primary care doctor and with your urologist like myself or Dr. Kiriluk about the specifics of this. But in general, these things can break. How often? It's pretty rare. Okay. They call it mechanical failure. If the thing gets punctured, if some of the tubing gets broken or the pump gets broken, it won't work. And unfortunately, it requires a revision surgery. Knock on wood, it doesn't happen that often, but they would need to be pulled out and put back in with a new one. You can get some shortening of the penis. You can get a little scarring from the implant. There is discomfort after the procedure, but typically that discomfort goes away after you're kind of out of the post-operative period. You have to be careful with anyone who's having insured surgeries when they have diabetes or they have wounds or anything. You just have to be careful when you're doing implants. Again, you can think of this similar to people who've had knee replacements or hip replacements. We use all the same precautions. So in summary, erectile dysfunction is extremely common. You're not alone. it's more common than not. So you just kind of have to think about it that way. There's lots of treatment options. Again, we offer all these treatment options. When they fail or you're not happy with them, implant's a really, really good option for you. It sounds scary, but the damn things work great. People are happy with them. If you can get over the process of getting the procedure actually done, then you'll be very happy with it. I always get this question. I like to let people know to put their mind at ease is, well, I don't want to go have a surgery and tell people I had to get a penis implant. There are certain people who don't mind, but the reality is, even if someone comes in, our staff is prepared to talk about their hernia surgery or whichever surgery you would prefer us to say you're having. So you can keep it discreet, meaning that, no one has to know if they don't want to know or you don't want them to know. So that process can be discussed beforehand, and we adhere to that process. So I hope you learned something, and I'm going to move on, and with Dr. Kiriluk is going to talk about his portion of the procedure about stress incontinence.
Well, thanks for joining us tonight. As Dr. Benson just mentioned, focus right now on stress incontinence of urine. If you want to go to the next slide. So it's important to distinguish between types of leakage of urine, and really what we're focusing on tonight is leakage of urine that happens after prostate cancer treatment, and that leakage is mainly from stress incontinence, which has to do with a muscle issue, meaning when you cough, sneeze, lap, the muscle that holds the urine in isn't strong enough and there's leakage. And it is important to distinguish between that and urge incontinence, overflow incontinence, some other things that can happen, but not necessarily are common after prostate cancer treatment. It is very common right after surgery for prostate cancer, where up to half of men will have leakage. And really, I tell patients after surgery, just expect it. It's going to be present, and then it gets better over time. And really, the interval I'm looking at is what happens after about 6 months from surgery. If you want to go to the next slide. So just a graphic of, again, what happens with urination, urinary control. You see the bladder up at the top of the screen. Right below the bladder is the prostate. The prostate's donut shaped. The urethra is a donut hole. And then right below the prostate is the muscle that holds the urine in. As the prostate gets bigger, it causes more blockage, which means the muscle doesn't have to work as hard. And so that's one of the reasons why urinary leakage can happen after surgery, and why it can take some time for there to be improvement after surgery, because really what we're looking at is improving muscle strength, improving muscle tone. Next slide. So, they say 9 to 16% of men have leakage of urine after surgery. Really what we're looking at, not so much as leakage, but amount of leakage. Having a drop or two of urine that comes out with a random cough or sneeze, that happens, some studies show up to 20% of the time. Having severe leakage of urine that requires multiple pads, that obviously impacts quality of life a lot more. Fortunately, after surgery, it's not as common. We say up to 2% of the time. You can have leakage of urine, stress incontinence for other reasons. It can happen with radiation treatment. Fortunately, it's not common, about 1-2% of men with that. We can occasionally see it after treatment for enlarged prostate, sometimes neurologic disorders or trauma. Next slide. From a quality of life standpoint, it can be severely impactful. Unfortunately, there are patients who require multiple pads or even depends after surgery and just do not get urinary control back. And that when that happens, it's every day, all day long, at night. And those are patients who really benefit from having additional treatment and really see big improvements and kind of the focus of the presentation going forward. Next slide. In terms of prostate cancer, very commonly diagnosed, 180,000 men a year diagnosed with prostate cancer. about a third of them having surgery for prostate cancer, and as was discussed earlier, a fair proportion of them that have leakage of urine. This is a graphic that Dr. Benson went through just a little bit ago that shows the nerves for erections. And what I'm looking at is the muscle that holds the urine in. That muscle is really small and again takes time to have improvements, and we'll kind of go with that in the next slide here, I think, or upcoming slides. Next slide. So again, expectations, improvement over time. I usually say 6 months for recovery rather than, we don't see much change after 6 months. Every now and then a little bit if someone has overactive bladder and some bladder issues. Most improvement, I would say, for men, we see maybe using 5-6 pads a day right after surgery. 2 to 3 months from surgery, many men are using 2 or 3 pads a day. 6 months from surgery, maybe a pad for safety, maybe nothing at all. Next slide. Short-term options. We don't like to reduce fluid intake as much. Sometimes we worry about some of the other effects of that, but it certainly can be part of a strategy, certainly at night before bed. Using interval breaks to go to the bathroom after prostate cancer treatment. The bladder capacity, as it gets more full, more pressure on the muscle, so going to the bathroom every 1 to 2 hours can help reduce some of the leakage. Pelvic floor therapy, I think, is very important after surgery, and usually we even recommend it before surgery. Studies show that doing Kegel exercises are really just kind of clenching the muscle that holds the urine in. Doing that randomly before surgery can help improve the time to recover after surgery and continuing with it after surgery. And then the coping mechanisms, using pads or thicker pads, diapers. Catheters are not something that we would usually recommend for leakage. Penile clamps have a role for some patients, but they are quite irritating, not comfortable to wear. I mean, essentially you're putting a clothespin on your penis, and it's not a great option for most men. Next slide. This is a little interesting just from a cost standpoint, not something that we think about on a daily basis, but added up over time. The pads, diapers are really expensive, $7,000 plus for 5 years if you're using 5 pads a day. So there is a significant cost aspect that can be part of it. Next slide. So if conservative measures aren't working, if someone's having leakage of urine that just is not getting better, given time and allowing for muscle strength, muscle improvement, there are really 2 approaches that we consider. One is called a sling, and one is the artificial sphincter. Sling is a little bit newer on the scene compared to sphincter, but both have been around for quite some time. And we use one for sling for a little bit less severe leakage, and artificial sphincter is considered to be more the gold standard, and what we use really potentially at any level of leakage. Next slide. I think we have a picture of the sling. So sling kind of goes, it's a surgical procedure where we're making an incision, and that incision is in a space called the perineum, the space between the scrotum and the anus. Through that incision, we essentially put a piece of tape or mesh that pulls up the urethra, adds added support, and really it's just physical pressure on the urethra that allows for improved urinary control. It's something that is an outpatient procedure, so patients come in, they have it done, they go home the same day. We say normal activities after a week or 2, although we always want to be careful after a sling that patients aren't doing deep squats, that are avoiding heavy lifting. We want the sling to heal in the right place to allow for appropriate urinary control. We don't want the sling to get dislodged and have more leakage. Next slide. The sphincter has essentially an inner tube that goes around the entire urethra. So it is physically replacing the sphincter muscle with a mechanical device. It is simple from a construction standpoint in that you have almost like the inflatable prosthesis that Dr. Benson was talking about earlier, a pump in the scrotum that you press a button, and that causes fluid to move out of the inner tube and into a reservoir. So the sphincter is always putting pressure on the urethra, and then when someone needs to urinate, they push the button, the inner tube opens up, they urinate normally, and then automatically that inner tube fills back up. It's all self-contained. It's not anything that anyone can see, and it's placed in a similar fashion to a sling through an incision, usually between the scrotum and the anus. Next slide. This is a video that kind of shows the sphincter, and it's similar to that last video, but you can see kind of where it is and how it functions. The button that's in place in the scrotum is actually quite small. It's not something that you can really see easily through the skin. Again, no one's going to really know that it's there. Very easy to use. We don't worry so much about manual dexterity with it. If someone has a little bit of a tremor, or they're not quite, don't have very good strength in their hands, it's still a fairly simple thing to utilize. Next slide. So, again, I think it's important, as Dr. Benson mentioned, we all deal with urinary incontinence here in the office, and we always want to start with conservative measures first, and if conservative things aren't working, go to the next step. And so all of us are equipped to handle these discussions. And if this is something that impacts quality of life, a lot of men just put up with things and don't realize that there are options that are great options for them to potentially pursue, and bring it up at the appointment. Talk to us about it. It's something that we oftentimes have an answer or some way we can help out. Next slide. Like any surgery, always risks. Unfortunately, anytime we put in an implant, there is a chance for failure. That holds true with both a sling and a sphincter. Urinary retention with a sling can happen. Usually it's short term, rarely is it longer term. Irritation tends not to be as much of a problem, but can occur. The sling is a foreign body. It's a piece of mesh. Mesh complications, there have been a lot of things in the media, potential lawsuits with mesh. We don't really feel that it's as much of a concern with the male sling, but it is something to be aware of. Sphincter has been around for an exceptionally long period of time, and as I mentioned before, historically viewed as a gold standard, can be used for any type of leakage, even the most severe cases. What I advise patients with, with a sphincter is that if they have a high degree of leakage, we might not get them 100% dry. We might get them to a point where they're 95, 97% dry, maybe wearing something like a liner for safety rather than going through, 5-7 pads a day. Long-term complications, erosion of the urethra with the cuff, infection, device failure, those are things that potentially could require surgical intervention. Next slide. Insurance coverage, again, not guaranteed, although I will say that most insurance companies do provide some degree of coverage. This is something that has been on the market for a while. It's not experimental. We always do with any surgery prior authorizations to get an idea about what coverage is going to be, what out-of-pocket expenses might exist. Next slide. So just a summary slide here. Again, stress incontinence after treatment of prostate cancer absolutely is a known condition. It can be a severe impact on quality of life, and certainly if it's something that's bothering a patient, we want to be able to address it, and we have options in terms of how we address it. Slings or sphincters are both the surgical option that we would consider, and something that can offer great long-lasting urinary control.